We have a few minutes for questions. We obviously won't get between you and the lunchroom or a minute of that. But anyhow, questions, please. I guess everyone is hungry.
Good morning. My name is Glenn Savado. I'm the co-founder of Eastaugh. It's a local company, startup, and we're a healthcare search engine that provides access and transparency for people searching for healthcare procedures. My question is, do you think with the popularity of HSAs increasing, that'll start to reduce the cost of healthcare procedures due to the fact that they'll be more market-driven?
The answer is yes. Do I think that HSAs are going to contribute to decreasing the cost through more competition? And the answer is absolutely. As I said, I'm a policy guy, so I can say this. I'm not a politician. Healthcare is an economic activity, folks. It's like food and shelter and clothing. And all of you in this audience are savvy consumers. I mean, you guys are smart. You know what the price of a pound of hamburger costs. You know what a house costs. You know what clothing costs. Healthcare is the same thing. And over time, call it a paradigm shift if you want, but over time, you can become savvy consumers of healthcare as well.
Yeah, exactly. So if you have a chance, check out pricedoc.com. and you'll see the future of healthcare. It's one solution. Thank you.
Well, look at two areas, cosmetic surgery and laser surgery. Those costs have been driven down significantly because generally insurance doesn't pay for either. So, you know, economics do work in healthcare, even though there's somewhat of a myth that it doesn't. Yes, sir.
I'd like to ask Dr. Matthews. I once asked legislators here in the state of Washington at one of our meetings about the mandates, and they assured me that we did not have mandates. And what we had was they had to be offered, but they were not mandated. Could you tell me the difference between these?
Yes, sir. The difference is zero.
That's what I thought.
And you'll find if you download we've got about 3 pages of discussion on this because we send out forms to every state department of insurance that we have them fill this out. Plus we have some other ways that we track it. In fact, we track all the legislation that's introduced at every state as it moves through the process. And we do have insurers that will come, I'm not saying insurers, but state legislators come up and say, this is not a mandate because we're only telling they have to offer it. Our actuaries, and we address this in the text before you get to the chart, our actuaries tell us there's no difference. If you're offering it, if you have to offer it, it's in essence a mandate that increases the cost. Because we use actuaries to do this because they're the ones that have to set the prices when the state comes up and says, you've got to cover these things, these things, and these things. The actuaries then have to go back and say how much we're going to raise the cost of health insurance premium in order to address that. So, no difference.
Yeah, in our block of business of about $500 million, we added about 4.7% for mandates across the country. Yes, sir.
I'm here as chair of the legislative committee for the Washington Rural Health Association, and one of the things that neither of you have commented on is the impact of how some of these statistics play out in rural areas. And I know from WRHA's own kind of research in this area that we have more uninsured in the rural areas because they aren't likely to be small business owners, self-employed, or making a full-time living out of part-time and seasonal work. So if you could both comment on the rural aspect of your two fields of expertise.
Okay. You're absolutely right. The rural population tends to be uninsured more so, and in large part because you've got migrant workers that move through these areas and don't have insurance. Creating a national insurance plan, unless you in essence create just a single payer system where a person can go to any hospital or doctor and get care, assuming there's not a waiting line, then you don't solve the problem. Giving migrant and transitory people insurance is not easy because there's no real place to be able, oftentimes they're not steady in some place long enough to be able for an insurance company to be able to work with them, have a permanent address that they can mail things to and things of that nature. You create some problems trying to create an insurance product for them, which is why you want to have an effective safety net out there. You need a good, for markets to work in health insurance, you need a safety net to capture those people who don't work well in the market. Transitory people oftentimes don't work well in the market, so you want to have that effective safety net.
Yeah, one of the beautiful things about an HSA is it doesn't care about geography and it doesn't care about who you work for, or if you work at all. And I think it's an excellent model whether you're in the city or you're in a rural environment.
One quick follow-up. There is a migrant portion to the population in some rural areas, but I'm actually thinking of places where it's third and fourth generation, too stubborn to move. And what we
Are too wise?
Yeah. And where we have a lot of aging in place and a lot of much older demographic in the rural areas, and so we have some needs that aren't being met in terms of home health and a lot of other things. So those really are two pieces of the rural. One is that migrant population, but a big piece of it is just long-term residents who want to stay and just need that infrastructure.
You know, it's an interesting point because, and I can tell you, the term underinsured was mentioned earlier today. I can tell you in Washington, the people moving healthcare reform feels that underinsured, that is a code word for high deductibles, limited benefit plans, and things of that nature. They think that is all junk insurance and people shouldn't have it. We, in fact, think that you would want to expand those, especially to these types of populations, where if the money is limited and there's not enough to go around, sometimes a minimal plan that provides 5 or 10 physician visits a year, some generic drug coverage, maybe some amount up to say $25,000 or so if you go to the hospital, but something which captures most of those costs that's very inexpensive. Sometimes that is a very good option. Those types of policies are out there, but oftentimes state legislatures, and I can tell you healthcare reform in Washington, does not like those policies and want to try to eliminate them.
Yes, ma'am.
Yes, I'm wondering, with the policy people that are here at this conference and are giving us all sorts of great information, and that the policy center cannot do political activities, but is there an organization or a place where we could try to get the policies that we know are good to be implemented? Is there a central source for that, or some way we can be pointed in that direction?
Well, we do that. We're a 501c6. So we actually work, I have federal people, state people that monitor these things and work on the legislation at the federal and state level. And I think most of you here would be amenable to the types of approaches that we take, which would be, I think, almost identical to what the Washington Policy Center does. So CAHI.org, you can go on that website and you will find a range of different things going on there, or you can contact us and we'll be glad to try to get you involved in it.
The Washington Policy Center is a 501c3, so we're not a lobby group, and we don't do those kinds of things.
I'm curious, the differences of mandates. We have 57, IWC has 13. Do you know the direct results of what their insurance policies and plans are costing versus what Washington State's are?
It is a very good question, because occasionally you will find people who want to, who say, this state has more mandates, therefore health insurance will be more expensive. If you look at our chart, the vast majority of mandates affect the cost of a premium less than 1%. Because oftentimes it's a fairly small expense, or it's targeting very few people. Some of them are more expensive. Mental health parity, where you raise mental health the same as physical, that's expensive. Substance, drug, and alcohol abuse, that's expensive. Even autism. The autism lobby loves us because we've been saying for some time that affects the cost of a policy less than 1%. That's changing because of the increase in autism and because the autism lobby is trying to get a whole lot more things covered under that. But because each state varies, let's just take a chiropractor for instance. One state may say you have to cover chiropractors at the same level that you cover a medical doctor. The next state may say you have to cover 5 chiropractic visits during the year. The next state may say you have to cover 50% of the cost of a chiropractor. Well, all of that varies depending upon what you're covering or what kind of exceptions and so forth you have. So we've been looking at this for 10 years with a group of actuaries. We've never been able to make a direct correlation between the cost of the number of mandates and the cost of an insurance policy. Minnesota has the most mandates. Health insurance there is actually fairly affordable, but it depends upon what they're doing with those mandates and how they implement them. So we'd like to be able to do that, but we've never been able to actually make a direct correlation. What we do know is that the number of mandates that you get, when you start getting into 30, 40, 50, 60 mandates, you are driving up the cost of a health insurance policy.
You know, our policies and ILO stop loss policies are 11% cheaper than they are in Washington, but I don't really attribute that to mandates so much as just provider costs are lower in Idaho than they are in Western Washington. I think that's about time. I think we're up for lunch just next door.